You know that feeling when you pick up a new prescription at the pharmacy?
Oh, yeah. You unfold that impossibly thin, tightly packed piece of paper.
Right, the one tucked inside the box.
Yep.
And you start reading, and suddenly a medication designed to help this, highly localized, highly specific issue reads like a Stephen King novel.
It really does. The list of potential systemic side effects just goes on and on.
Exactly, until you're genuinely wondering if you should just throw the tube straight into the trash.
Which is a completely human reaction, by the way.
Yeah, and imagine that medication is a potent steroid, and you are being told to apply it to one of the most sensitive areas of your body, your genitals.
Right. It's terrifying. As patients, we desperately want the cure,
Yeah.
but we are, deeply afraid of the collateral damage.
For sure.
There's this built-in assumption that if a warning is printed in bold ink on an FDA-approved insert, it must be an absolute certainty for anyone who uses it.
Which is exactly why we're tailoring today's deep dive specifically for you, the listener. We are going to separate those terrifying generalized warnings from the localized reality of actual human biology.
It's so important to draw that line.
It really is. Our mission today is highly specific, but if you or someone you love deals with chronic skin conditions, it is incredibly important. We're asking, does the long-term use of ultra-potent topical steroids for a condition called lichen sclerosus, or LS for short, actually cause systemic adrenal suppression?
It's a huge question in the dermatology and gynecology space right now.
Yeah, and we are pulling from a really dense stack of medical literature today to answer it. We're looking at the British Association of Dermatologists guidelines, pharmacokinetic reviews from Sexual Medicine Reviews, safety updates from the UK government, and some truly eye-opening real-world clinical case studies.
There's a lot of ground to cover.
There is, but we're breaking this all down so you can be fully informed without all that overwhelming medical jargon. So, okay, let's unpack this.
To really understand the fear surrounding the treatment, I think we have to start with the daily reality of the disease itself.
Right. Lichen sclerosus.
Yeah, lichen sclerosus is a chronic inflammatory condition that primarily attacks the angenital skin. And, this isn't just a mild rash.
No, not at all.
For the people living with it, LS can cause severe, unrelenting itching, microscopic tearing of the skin, and just intense pain.
In reading through these sources, the stakes of leaving it untreated are incredibly high. Like, it's not just about managing discomfort, right?
Not at all. Left unchecked, the inflammation can cause permanent anatomical changes.
Which is just, that's scary.
Yeah, the skin can actually fuse together, creating severe scarring that fundamentally alters how a person's body functions.
Wow. Which brings us to the frontline defense, the gold standard treatment to stop that inflammation in its tracks, which is ultra-potent topical corticosteroids.
Exactly. In most clinical settings, we're talking about medications like clobetasol, propionate, 0.05%.
Right. But right alongside that gold standard recommendation is the massive bold print fear we talked about, the one that makes patients, leave the cream in their bathroom drawer.
And it even makes some general practitioners hesitate to prescribe it, honestly.
Right. And it's called hypothalamic pituitary adrenal axis suppression, or HPA suppression.
Yes.
I know we throw the word hormones around a lot, but what is physically happening inside the body when someone experiences HPA suppression?
What's fascinating here is how the body manages itself. The easiest way to visualize the HPA axis is to picture your body's natural stress management factory.
Okay, the factory.
Yeah. And the primary product this factory manufactures is cortisol. Now, cortisol gets a bad reputation as the stress hormone, but it is, vital for human survival.
Right, you need it.
Exactly. It regulates your metabolism, reduces inflammation, and most importantly, it controls your blood pressure during acute stress.
So it's essentially the thing keeping you upright and functioning when things go wrong.
Precisely. Now, imagine you introduce a strong exogenous steroid into the body.
Exogenous just meaning from the outside.
Right.
Like a pill or a cream.
Right, from the outside. Your body's internal sensors detect all this extra steroid floating around in the bloodstream. The factory management looks at the inventory and says, oh, we have plenty of this steroid material on hand. Shut down the assembly line.
Wow.
So the body just halts its own natural production of cortisol to compensate.
The factory just boards up the windows and goes dormant.
It does. And in a vacuum, a dormant factory might not seem like an emergency. The real danger happens if your body suddenly faces a massive external stressor.
Like what?
Imagine you get into a severe car accident, or you need emergency appendicitis surgery, or you catch a severe systemic infection.
So situations where you desperately need that factory running at maximum capacity.
Exactly. Normally, your HPA axis would immediately pump out a massive surge of cortisol to keep your blood pressure stable and keep your organs functioning.
Right.
But if your adrenal function has been suppressed by outside medications, the factory can't turn the lights back on fast enough to mount that defense.
Oh,
Yeah, your blood pressure can plummet, you could experience severe dizziness, fainting, or even go into a full-blown, life-threatening state called an adrenal crisis.
okay, well, when you explain it like that, the fear makes complete sense. Like if I'm a patient reading that insert, I'm thinking, I have a localized fire in my kitchen. The doctor just handed me a fire hose, and I am terrified that if I turn this thing on, I'm going to blast through the floorboards and flood the entire foundation of my house.
That is a perfect analogy.
But I have to stop and ask the obvious question here. If clotrimazole is the undisputed, universally recommended gold standard for treating lichen sclerosus, why does the warning label read like we're risking a total foundation collapse?
Because the warning label isn't technically false, but it is entirely devoid of scale.
Okay, what do you mean by that?
It's a generalized one-size-fits-all warning slapped onto a highly specific low-volume application. We have to move away from the conceptual fear of the fire hose and look at the actual mathematics of how much water is being sprayed.
Right, the actual numbers.
Yeah. When we look at the clinical data, HPA suppression from topical steroid use alone is exceedingly rare.
Let's actually look at those numbers because the gap between the warning and the reality is staggering. According to the British Association of Dermatologists, for an adult to genuinely enter the danger zone of suppressing their adrenal factory with the topical cream, they have to use a massive volume.
We are talking about 200 grams or more of very potent clobetasol per week, applied to large swaths of the body continuously for 4 weeks or more.
200 grams. To put that into daily terms, you would have to absorb roughly 2 entire grams of this ultra-potent medication every single day.
2 grams a day, 14 grams a week.
But what is the actual standard recommended dose for a patient maintaining vulvar lichen sclerosus?
The recommended maximum dose for maintaining vulvar LS is just 10 grams per month. Often it's prescribed as roughly 30 grams stretched out over a 3-month period.
10 grams a month. So to hit the danger zone, a patient would have to use their entire 1-month supply of medication every 5 days, and they'd have to do it for a month straight.
That is the mathematical reality. The volume of medication required to maintain remission for LLS is microscopic compared to the threshold required to shut down the HPA axis.
That is a huge difference.
It is. This massive canyon between the required dose and the toxic dose is why the British Association of Dermatologists explicitly does not routinely recommend a steroid emergency card for adults using topical corticosteroids alone for limited skin diseases.
An emergency card being the medical alert bracelet or card a patient carries so paramedics know to inject them with cortisol during trauma.
Right. For an adult treating limited LS with standard therapy, the dosage is simply too low to trigger the factory shutdown.
The math is incredibly comforting.
The math is comforting, but I know my own body doesn't always follow a textbook, and I want to push on this a little bit.
Sure. Because as I was going through the sexual medicine reviews source, I found something that felt like a glaring contradiction. We just established that the volume of cream is tiny, but volume is only half the story, right? We had to talk about how the body actually absorbs things.
Oh, right. You're talking about the pharmacokinetics.
Yes, pharmacokinetics. The actual mechanism of how a drug moves into and through the body. The source breaks down absorption rates by body part, and it varies wildly.
Yeah, it does.
Like, for example, if you rub a steroid cream on the soles of your feet, only about 0.5% of that medication is actually absorbed into the bloodstream.
Which makes anatomical sense if you think about it. The soles of our feet are covered in thick, heavily keratinized calluses designed to withstand us walking around all day. It's a tough barrier for a cream to penetrate.
Makes perfect sense. Then you move up to the forearms, and it's about 1% absorption. But then we get to the sensitive tissues.
Right. Yeah.
If you apply a topical steroid to your eyelids or to your genitals, the absorption rate skyrockets to 30%.
Yeah, 30% is the standard figure there.
The skin on the eyelids is paper thin, packed with capillaries right at the surface. So my question is, if the genital tissue acts like a sponge and absorbs 30% of whatever you put on it, shouldn't we be deeply worried about that ultra-potent clobetasol hitting the bloodstream even if it's only 10 grams a month?
It is the most logical question you could ask,
Hmm.
and it's the exact reason why this topic requires a deep dive rather than just, reading an internet summary.
Yeah.
Because that general physiological rule that genitalia absorbs 30% of a topical medication simply does not apply to a patient who has lichen sclerosus.
Wait, why not? General tissue is general tissue, isn't it? It's all modified mucous membrane.
It is until the disease alters it.
Mm.
This is where we have to look at the pathology of lichen sclerosus. The disease fundamentally terraforms the landscape of the skin.
Terraforms it.
Yeah, think about the stratum corneum.
That's the outermost protective layer of the skin, right? The dead cells that form the barrier.
Exactly. On normal genital skin, that stratum corneum is quite thin, which allows for that high 30% absorption rate.
Okay, tracking.
Even when skin is afflicted by a severe inflammatory condition like psoriasis, the stratum corneum might only thicken to about 40 to maybe 100 micrometers.
Okay, so under 100 micrometers, still relatively thin.
But when lichen sclerosus attacks the tissue, the skin reacts by hyperthickening defensively. The stratum corneum in LS-affected tissue becomes a staggering 1,200 micrometers thick.
Wait, 1200, so it goes from being a thin, porous sponge to a foot-thick concrete wall.
It becomes a fortress, and that 1,200 micrometer barrier disrupts everything we know about normal pharmacokinetics. It largely prevents what dermatologists call the reservoir effect.
What is that? The reservoir effect.
In normal skin, a potent steroid can absorb deeply into the tissue, pool up like an underground reservoir, and then slowly leach into the systemic bloodstream over days or weeks.
Oh, I see.
But because of the massive thickening caused by LS, the clobetasol can't penetrate deep enough to form that reservoir.
Wow.
Yeah, the medication stays highly localized right at the surface where the inflammation is happening. It does its job fighting the disease locally, rather than crossing over into the blood and traveling all the way up to the adrenal glands.
That completely flips the script. The disease itself, the very thing causing the suffering, builds the physical barrier that prevents the treatment from causing systemic side effects.
The context of the tissue matters just as much as the potency of the drug. And we have clinical biopsies backing this up, by the way.
Oh, really?
Yeah. Researchers took tissue samples from women who had been using twice daily clobetasol for up to 22 months.
22 months. That is a significant duration.
It is. And the biopsies showed zero histological skin atrophy.
Meaning the steroid didn't cause the skin thinning that everyone is so afraid of?
Right. Because the disease was causing pathological thickening, the steroid was simply restoring a baseline balance. It wasn't thinning healthy skin, it was treating diseased, thickened skin.
Okay, the math is incredibly low, and the anatomy provides a literal 1,200 micrometer shield. I get why this is considered safe for the average adult, but science always has outliers, and I know our listeners are wondering about their own specific situations.
Absolutely.
Let's talk about the exceptions. When does the danger of adrenal suppression actually become a real, tangible threat?
We have to look at two major wildcards highlighted in the medical literature: age and cumulative steroid use.
Okay, let's tackle age first, specifically pediatric cases.
Right. The sources highlight a highly revealing case study of a 10-year-old girl. She presented with vulval and perianal lichen sclerosus and was prescribed clobetasol. But over the course of just 2 months, she went through 60 grams of the medication.
60 grams in 2 months. We just established that an adult shouldn't exceed 10 grams a month. That is a massive, massive overdose.
It was a severe overuse. The cream was applied very liberally, and crucially, they kept applying that heavy dose even after the inflammation had resolved and the skin barrier had returned to normal.
Oh, so the fortress wall was gone, but they kept using the fire hose?
Exactly. Because of this, she did develop an impaired cortisol response. Her HPA factory started to shut down. She also showed physical signs of steroid toxicity, like marked, deep stretch marks, which we call striae.
Beyond just the sheer volume of the overdose, why is a 10-year-old so much more vulnerable to this than an adult?
It comes down to basic biological geometry. Children have a much higher total body surface area relative to their overall weight or volume compared to adults.
Okay, how does that play out in practice?
Think about a child's proportions. Their head and skin surface make up a much larger percentage of their total mass. If you put a pea-sized dollop of steroid cream on a child, that medication is covering a significantly larger percentage of their total body mass than that exact same dollop on a fully grown adult.
Oh, I see.
It means they absorb a proportionally higher dose systemically.
But looking at the follow-up in the study, the damage wasn't permanent, right?
No, thankfully. Once the dosage was corrected, her adrenal function returned completely to normal within 15 months, and her LS remained in remission. But it's a stark reminder that pediatric prescribing requires intense monitoring. You cannot just hand over a tube of clobetasol and say, use as needed.
Right, that makes total sense. So pediatric surface area and massive overdosing is the first wild card. But what about the adults listening right now? If they are strictly following the 10-gram-a-month rule, is there a hidden trap they could still fall into?
The biggest hidden trap is cumulative use. And I would encourage everyone listening to mentally scan their own bathroom cabinets right now.
Okay, looking for what?
Other steroids. The human body does not compartmentalize steroids based on how they enter the body. It doesn't care if a steroid comes from a topical genital cream, an over-the-counter nasal spray for allergies, a pill for joint pain, or an inhaler. It all drains into the same systemic bucket.
So if you're taking multiple things, that bucket can overflow.
Precisely. And the biggest culprit we see in the data is asthma inhalers, specifically inhaled corticosteroids like beclomethasone.
Wow, really? Inhalers?
Yeah, the clinical data shows that roughly 10% of patients who are on high-dose steroid inhalers for asthma already have some baseline level of HPA axis suppression. Their cortisol factory is already partially powered down just from breathing in their daily asthma medication.
So what does this all mean? If you take an adult whose factory is already running at 80% capacity because of an inhaler, and you add an ultra-potent topical steroid on top of that, even a perfectly dosed tiny amount of clobetasol, that could be the final drop that overflows the bucket.
That is exactly the risk. It's the compounding effect.
Yeah.
And in those specific combination cases, the guidelines suggest that carrying a steroid emergency card might actually be warranted because the patient's systemic threshold for suppression has been artificially lowered by that secondary medication.
Which brings us to an incredibly frustrating reality. We've spent this time breaking down the very specific, mathematically and anatomically rare scenarios where adrenal suppression actually happens.
Right.
But this deep-seated fear of topical steroids isn't just paralyzing patients, it is actively influencing how specialized medical professionals treat or fail to treat their patients.
If we connect this to the bigger picture, it is, and the sources provide a textbook example of this danger.
Yeah.
There's a case study of a 52-year-old woman who was being successfully treated for lichen sclerosus.
Okay.
She was incredibly diligent. Over an entire 12-month period, she used an estimated total of just 30 grams of clobetasol.
30 grams in a year. That is less than 3 grams a month. She is well below the 10-gram safety limit.
She was using a microscopic amount by clinical standards. But she went to her doctor complaining of profound fatigue and recurrent, unexplained falls. They ran blood panels, and the testing revealed she had secondary adrenal insufficiency.
Let's clarify that term quickly. How is secondary adrenal insufficiency different from a primary issue like Addison's disease?
In primary insufficiency, like Addison's, the adrenal glands themselves are physically damaged or destroyed, often by an autoimmune attack. The factory is basically burned down.
Got it.
In secondary insufficiency, the adrenal glands are perfectly healthy, but the signal from the brain telling them to produce cortisol has been turned off. The factory is fine, but management cut the power.
And because exogenous steroids turn off that signal, her endocrinology team saw the clobetasol on her chart and immediately blamed the cream.
Exactly. They took one look at her medication list, saw the words ultra-potent topical steroid, determined it was the cause of her secondary suppression, and they completely stopped her lichen sclerosus treatment.
The logic there is maddening. She's using 3 grams a month on a 1,200 micrometer thick skin barrier.
I know.
Blaming the clobetasol for her systemic failure is like finding a puddle in your basement during a hurricane and blaming the single drop of condensation that fell off a cold soda can. It defies all statistical and physiological reality.
It highlights a pervasive issue in medicine, which is steroid phobia. And here is the ultimate revelation of that case study. 5 months after the endocrinologist abruptly stopped her topical steroid, they retested her adrenal function. It hadn't changed. It hadn't improved even a fraction of a percent.
Because the clobetasol wasn't the culprit.
It was entirely innocent. Her endocrinologist actually had to go back into her medical charts and formally amend their diagnosis to secondary adrenal suppression of unknown cause.
Wow. But in the meantime, they stopped her treatment. And stopping that treatment isn't just about letting the itch return.
No, stopping it is incredibly dangerous. Uncontrolled lichen sclerosus leads to those intense architectural changes we discussed, the fusing of the vulvar tissue, severe scarring, the loss of normal sexual and urinary function. But even more critically, leaving that localized inflammation unchecked significantly increases the patient's risk of malignant progression. We are talking about an increased risk of developing squamous cell carcinoma, a serious type of skin cancer.
So they risked letting her develop cancer to save her from a statistically impossible side effect.
Basically, yes.
And on top of that, suddenly stopping a potent steroid cold turkey carries its own nightmare scenario. The UK government safety updates spend a lot of time warning about TSW, topical steroid withdrawal reaction.
Yes, TSW is a severe systemic rebound effect. When you abruptly withdraw steroids, especially higher potency ones, the body can overreact. Patients experience intense redness, severe burning, stinging, and skin peeling that can actually spread far beyond the initial treatment area.
By reacting to a generalized warning label instead of the localized pathology, the doctors put this woman at risk for withdrawal, permanent anatomical scarring, and cancer.
It perfectly illustrates why specialized, localized knowledge is critical. You simply cannot apply general physiological rules like a standard 30% genital absorption rate to pathological states like lichen sclerosus. The unique context of the disease dictates the safety of the cure.
So, to bring all of this together for you, the listener, we started with a very specific question. Does the long-term use of ultra-potent topical steroids for lichen sclerosus cause systemic adrenal suppression?
Right.
Based on the pharmacokinetic data, the clinical biopsies, and the actual dosage limits, the answer is that when used at the recommended low doses by adults, it is highly, highly unlikely.
Very unlikely.
The anatomical changes of the disease itself create a thick fortress wall that prevents deep absorption, and the low volume of medication requested by dermatologists keeps you safely out of the systemic danger zone.
Exactly.
The primary risks of adrenal suppression only really materialize in pediatric cases, in severe instances of massive overdosing, or when you are combining the topical cream with other systemic steroids that fill up your body's bucket, like daily asthma inhalers.
The clinical math and the physical anatomy are overwhelmingly on the patient's side here. The gold standard treatment remains the gold standard for a very good reason.
Which leaves us with a final thought for you to ponder today. We started this deep dive talking about the very human fear of unfolding that terrifying pharmacy package insert. We expect modern medicine to be simple, black and white, cause and effect.
But it rarely is.
Exactly. But we've seen today how a generalized fear of a drug's side effects, printed in bold FDA ink and even believed by specialized endocrinologists, can almost completely derail the safe, effective, and absolutely necessary treatment of a highly localized disease.
It's a huge problem.
It really makes you wonder how many other medical conditions out there suffer from this kind of treatment paralysis. If we can misunderstand the localized safety of topical steroids this badly for a condition like lichen sclerosus, what other gold standard medical treatments are patients and even doctors needlessly abandoning right now out of a misplaced, out of context fear of the cure?
It is a profound question, and one that every patient should feel empowered to bring up in their doctor's office.
Until next time, keep looking past the warning labels and keep digging into the deep dive.